Amenorrhea. It is defined as amenorrhea of 6 months or more in a woman with previous normal menstrual pattern in the absence of pregnancy and lactation. However, in clinical practice, patients seek advice earlier, and it is prudent to begin with simpler investigation and reassurance and wait the outcome. Etiology. They can be similar to that of primary amenorrhea. However, dysfunction of the hypothalamic pituitary ovarian uterine axis accounts for majority of the cases of pathological secondary amenorrhea. They can be classified as physiological and pathological. Physiological can be during pregnancy, lactation. Pathological can be from genital tract due to an acquired obstruction, gynatresia of the cervical canal causing severe stenosis or atresia following electrocauterization, chemical burn, cervical amputation in father-kill repair operation, conization for cervical dysplasia or intraepithelial neoplasia, genital tuberculosis, vaginal atresia due to scarring following a traumatic delivery, Asherman syndrome following excessive curettage, uterine infection, endometrial tuberculosis, transcervical resection of endometrium for abnormal uterine bleeding and uterine packing in the postpartum hemorrhage, vesicovaginal fistula. Variant causes include surgical extirpation, radiotherapy, autoimmune disease, indication of multiple ovulation and infertility leading to premature menopause, PCOD, resistant ovarian syndrome due to absent FSH receptors, infections like mumps, tuberculosis, and in rare cases, pyogenic infection, masculizing ovarian tumors, premature menopause. Nutritional causes include anorexia nervosa, bulimia, extreme obesity, excessive weight loss in athlete and ballet dancer. Pituitary causes include insufficiency and Simon's disease, Sheehan syndrome. Hyperprolactinemia, tumors such as prolactinoma, chromophobiadenoma, Cushing's disease, empty sella syndrome, drugs like tranquilizer, oral contraceptive pills, metoclopramide, dopamine blockers, antihistaminic, antihypertensive, antidepressant, cimetidine, phenothiazine. Hypothalamic causes like GnRH deficiency, vigorous exercise like stress or obesity, pseudocysts, brain tumors, anorexia nervosa. Suprarenal causes include Addison disease, adrenogenital syndrome, suprarenal tumor. Thyroid, hypothyroidism, chest wall lesions, Graves' disease. Other causes may be diabetes, tuberculosis, renal disease due to reduced excretion of LH and prolactin, severe anemia, malnutrition, idiopathic or genetic, resistant ovarian syndrome. Ovaries fail to respond to gonadotropin hormones and cause amenorrhea. The ovaries show plasma cells and lymphocytic infiltration. Biopsy, however, is not necessary for the diagnosis. FSH level is high. It may be prudent to study anti-thyroid, rheumatoid factors, and anti-nuclear antibodies to establish autoimmune disease. Pregnancy with a donor egg in the in vitro fertilization is possible. Simon's disease. It is related to pregnancy and Sheehan syndrome following severe postpartum hemorrhage caused pituitary necrosis by thrombosis of its vessels and panhypopituitarism. The woman fails to lactate following delivery, remains lethargic, shows signs of hypothyroidism and cortisol deficiency. She requires appropriate hormonal support. A young woman may require ovulation induction drugs to achieve conception. Management of secondary amenorrhea. The clinician must attempt to answer the following 6 questions. Investigations in amenorrhea. If secondary sexual characters are absent, the height is checked. If it's short height, FSH and LH levels are noted. If they are low, then it might be an intracranial lesion. If they are high, karyotyping is done. If it's an XO or a variant, then it's Turner syndrome. If the height is normal, FSH and LH levels are low, then it may be due to hypogonadism. If the FSH and LH are high, karyotyping is done. If it's XO or XX, it may be premature ovarian failure, it may be resistant ovarian syndrome or gonadal dysgenesis. If the karyotype is XY, it may be gonadal agenesis, testicular feminizing syndrome, or enzymatic failure. If the secondary sexual characters are present, ultrasound is done. Uterus is, if it's absent, karyotyping is done. If it's 46XX, absent uterus and vagina mean Rokitansky-Kushner-Meyerhoff syndrome. If it's 46XY, it may be testicular feminizing syndrome. If the uterus is present and ovaries are enlarged, check if ovaries are enlarged, outflow obstruction, it may be cryptomenorrhea. If the anatomy is normal, hormone assays FSH, LH, prolactin are done. If all are normal, it may be just delayed menarche. If LH to FSH ratio is high, it may be PCOD. If FSH is high, it can be Turner syndrome, resistant ovary syndrome, or premature menopause. If both are low, then it may be pituitary failure or any hypothalamic failure. If the prolactin is high, it may be hyperprolactinemia or a prolactinoma tumor. Skull X-ray is done. If the secondary sexual features are showing hirsutism, then it may be PCOD due to adrenal tumor or an ovarian tumor secreting androgens. Investigation. Pregnancy is the most common cause of secondary amenorrhea, so it should be excluded before proceeding. The next test is for elevated levels of serum prolactin. Prolactin secreted by anterior pituitary is normally under inhibitory effect of hypothalamus by dopamine. It's stimulated by estrogen and suckling. It is also present in the decidual and amniotic fluid. These levels fluctuate periodically. Therefore, several measurements may be needed to confirm hyperprolactinemia, which is defined as persistent high level of prolactin in a non-pregnant and non-lactating woman. The causes may be during sleep, stress, nipple stimulation, herpes zoster, empty cell ataxia, hypothalamic tumor, pituitary tumor or head injury, 20% case of PCOD, and some cases of endometriosis. Hypothyroidism because of stimulatory effect of raised TSH, liver and chronic renal diseases because of altered metabolism and delay in excretion. Drugs such as neuroleptic, narcotic, antidepressant, phenothiazine, antihypertensive, calcium channel blockers, OC pills, estrogen, cocaine, amphetamine, cimetidine, haloperidol, metoclopramide. The woman presents with oligomenorrhea culminating in amenorrhea due to suppression of FSH and LH. 50% of the cases develop galactorrhea. Infertility and abortion through corpus luteal phase defect are other features. Headache and visual disturbances occur when the tumor presses upon the optic nerve. In males, it causes loss of libido, impotency, infertility. Normal level of prolactin is 25 nanogram per ml. Levels up to 100 nanogram per ml suggest hyperprolactinemia. More than 100 nanogram per ml occurs in presence of a tumor. CT, MRI and visual checkup are necessary in the diagnosis. Thyroid functions need to be checked. Treat the cause. Drug-induced hyperprolactinemia requires stoppage of the drug or alternate therapy. Bromocriptine and long-active derivatives are effective in most cases. Menstrual cycles are restored in 3 months. About 90% ovulate and 70 to 80% conceive. Quinabolide 25 to 150 mg daily in divided doses with a maintenance dose of 75 mg daily. Drug microadenoma more than 10 mm and microadenoma not responding to drugs require transpenoid adenectomy or radiotherapy of 4500 curie gyre for 25 days. Evidence of estrogen deficiency. Hot flushes, loss of breast mass, dyspareunia, dryness of vagina are suggestive of lack of estrogen and premature menopause. It requires estrogen replacement therapy. Positive progesterone challenge test. It depends on the presence of estrogen primed endometrium in the uterine cavity. The test is considered positive if the patient responds to administration of oral tablet, medroxyprogesterone, Provera, Modus or Diveri, 10 mg daily for 5 days, or injection progesterone 100 mg intramuscular or Primolit 5 mg 3 times a day for 3 days. Withdrawal bleeding occurs within 2 to 7 days. A positive test indicates amenorrhea secondary to anovulation. Most common causes are hypothalamic dysfunction and PCOD. A negative test requires estradiol 0.02 mg or conjugated estrogen 1.25 mg for 25 days and progesterone from 16th to 25th day. A negative test usually suggests endometrial unresponsiveness in the presence of normal FSH. Pituitary. In Simon's disease, due to panhypopituitarism, woman is lethargic, blood sugar, thyroid functions are low. When postpartum hemorrhage causes vascular thrombosis of the pituitary vessels, panhypopituitarism known is called as Sheehan syndrome. CT and MRI detect a tumor. FSH, LH are required. Hypothalamic dysfunction is the most frequent cause of secondary amenorrhea. No specific cause can be found in majority, but a careful history may reveal a precipitating factor. Stress and drugs may contribute to amenorrhea. Stress situations are often poorly recognized by the patient. Examination, change of jobs, economic problem, breaking up of relationships, etc. A prolonged use of phenothiazine and tricyclic antidepressant affect the dopaminergic system in the CNS and are associated with raised levels of prolactin hormone. Post-pill amenorrhea 1%. Following the use of OC pills is also the result of hypothalamic dysfunction. Diagnosis is made only if spontaneous menses do not resume after 6 months of stopping of the pill. In such women, changeover to an OC pill with higher estrogen content, ethinyl estradiol 0.05 mg daily for 21 days cyclically for a few cycles helps to restore normal cycles. Weight change, amenorrhea are not uncommonly seen in clinical practice. Younger adults and girls and working women are often subjects of the disorder. A weight loss exceeding 15% of the ideal weight may predispose to the woman to menstrual disturbances. Investigation at this stage may reveal normal LH-FSH levels and the patient will respond positive to progesterone test. However, as weight loss increases further to 25% or more, low levels of hormones, namely gonadotropin and estrogen, are observed, and these are often accompanied by thyroid dysfunction. Proper counseling and advice to regain weight often suffices. However, there is a subgroup of patients who resist advice and may require psychiatric treatment. PCOD is associated with abnormal gonadotropin secretion, revealing an increased ratio of LH to FSH exceeding 3:1, which differentiates patients of PCOD from patients with hypothalamic dysfunction. In patients with PCOD, ovarian steroidogenesis is abnormal, leading to an increased production of androstenedione and testosterone, which in turn predisposes the patient to hirsutism, acne, and menstrual irregularity. The diagnosis is established on the basis of clinical suspicion and increased LH-FSH ratio, sonography, revealing enlarged ovaries with multiple peripheral cystic follicles. Laparoscopy reveals bilateral enlarged ovaries with thickened tunica albuginea and multiple cystic follicles. Ultrasound scanning helps in the diagnosis of PCOD, ovarian tumor, uterine lesions such as hematometra and Asherman syndrome. Specific treatment will depend upon the cause and the patient's desire for fertility at the time of consultation. If she desires fertility, treatment of choice is induction of ovulation with clomiphene citrate or gonadotropin. On the contrary, if the patient does not wish for fertility, she may be advised a progestogenal agent, methotrexate or dydrogesterone for 7 to 10 days every 2 months or so to induce the periods. This treatment protects the patient against ill effects of endometrial hypoplasia, adenomatous hypoplasia, and endometrial carcinoma due to prolonged unopposed estrogen action on the endometrium. These patients should be advised to use some form of contraception to safeguard them against any unwanted pregnancy. Premature menopause often requires hormone replacement therapy to protect against osteoporosis and avoid menopausal symptoms. Hysterosalpingogram or preferably diagnostic hysteroscopy helps in establishment of Asherman syndrome. Operative hysteroscopy to lyse the synechiae followed by cyclical hormones along with high dose of conjugated estrogen 2.5 to 5 mg per day for 3 to 6 months results in restoration of menstruation in about 50% of the cases. Some surgeons prefer to insert an intrauterine device in the uterine cavity after the lysis of adhesions to ensure keeping the cavity patent and prevent recurrence of adhesions. Hypoestrogenic subjects of secondary amenorrhea have serum estrogen levels less than 30 picogram per ml and benefit with estrogen and progesterone therapy. Asherman syndrome is caused by DNC, medical termination of pregnancy, uterine packing in PPH, uterine infection, tubercular endometritis. It causes amenorrhea, oligomenorrhea, dysmenorrhea, habitual abortion, and infertility, depending upon the extent of uterine cavity obliteration.